Good morning, everybody. We're going to start the first session, the first morning session, with a plenary session devoted to dual pathologies. I am part of the board of this session, and this is not usual because normally when I organize something and I am in charge of the organization of the colloquium. So then the board that organizes normally does not participate in chairing the sessions. But well, this is quite symbolic because today, well, in France, there's the first meeting devoted to dual pathologies in the framework of an agreement, a partnership agreement with the World Association of Dual Disorders. And, well, this association was created some years ago, and we have to underline the very important role that our Spanish colleagues have played when it comes to making this concept of dual pathology more visible. They have organized a space for work around all these issues about dual pathologies, so dual diagnosis, that is both addictive disorder plus mental pathology. And well, in France and in many other European countries, comorbidities and dual pathologies have to go a little bit further because it is not only a matter of psychiatric comorbidity, because it is two pathologies that are interacting one on the other. So this approach is missing in many practices and in many countries because we know that the approaches that are just focused on the psychiatric side, well, they're going to refer to an addictology team, a person who would be suffering from an addiction problem, and the other way around. And we know that it is not enough. This is what Anglo-Saxons are calling for. They want a comprehensive treatment. They want care provided, maybe not by the same therapist or one single therapist, but by a team that is devoted to the whole pathology. So, well, we have to promote this kind of approach. And we wanted the co-chairman of the session to be very involved people, very much involved, really, in the concept and in the implementation of this approach and the structuring of this approach. And all of this, of course, thanks to the association that was created. So, well, we've got many colleagues here, Dr. Weiss from Boston, and our friends who were kind enough to make us become members of the Spanish Association of Dual Pathology, and all the speakers, Yifrah KAMINER, and all of the speakers are part of the team, and some of them are founders of this working group on dual pathologies. And José Martínez Raga is a very well-renowned person in Valencia. And Carlos Roncero, he is living in Barcelona, but also in Salamanca, and he's the vice president of the association, the Spanish Association of Dual Pathology. And well, they have both really worked very hard on this field. So I'm so happy to have them here with us. And we're so happy for their support to the French group of dual pathologists. So I'm going to give the floor to Pepe, who's going to introduce the first speaker. Well, thank you very much, Jean-Pierre. I am sorry because I do not speak French. So, well, I'm going to speak Spanish, and I am very sorry. And, it is really an honor to be here at the Congress. And,
Como interesado en la patología.
And we're interested in dual pathologies, of course, and the fact that this effort is taking place every 2 years. I mean by this, the organization of this conference. Well, this is something that is really worth it. I'm going to present Yifrah KAMINER, but to me, it is an honor also to be here with Roger Weiss, because I trained with him, and there is also a very good friendship with ICRO. So, well, we have a spectacular panel ahead. Yifrah is a specialist in child psychiatry, children's psychiatry, infant psychiatry. And I'm sorry, only in English. It's English. It's
Yeah.
In English?
English, yeah, sure. In English, is it better?
Yes.
Okay. Sorry, I didn't realize there was no translation from Spanish to French. So I'm very happy to be here. So without any more preamble, I'm pleased to introduce Yifrah KAMINER, who is a child and adolescent psychiatrist from the University of Connecticut and the Alcohol Research Center. He's one of the most prominent figures in child-adolescent addictions and dual disorders, as well as with very vast interest beyond science, with a lot of publications, books, and even books on poetry and other areas. So without any more preamble, Yifrah.
Bonjour à tous. Je suis très heureux de présenter à Ville de Haiphong. And now, of course, I'll switch to English. And you didn't need this translation. Dr. Martinez just told you how wonderful we are. So, you know, it doesn't matter in what language. In any case, since my interest and work is with adolescents, I feel like a Baptist priest or a motivational speaker, because I need to advocate for adolescents, and adolescence is actually the most neglected sector of society in almost any terms, including mental health and including in substance use disorders, allocation of resources, training, and so forth. So even if you folks do not work with adolescents, I want to ask you one favor. Ask your patients if they have children at home, because if they do, probably these children have some issues, whether it's mental health and or substance use disorder equal dual diagnosis. This is extremely important, because a lot of time people who work with adults have some kind of a scotoma, blind spot. They just see adults, they don't see children. So this is my request from you. So this is my disclaimer. I would like to ask thank John Kerry from Duke University, who's my collaborator on a study that is still going on, but I will share with you some information. And I get some federal support. And my kids told me to let you know that they would like me to sell as many books as Harry Potter. So please check me online. And I have a book on dual diagnosis, and I have a new textbook coming up. So this is what a slide of our ongoing study looks like. This is how we recruit subjects, patients. Originally, it was up to age 18, but it's very interesting. We found out that it's more difficult to recruit adolescents, meaning 12 to 18 in high school, than recruit college students, aged 18 to 21, or in the United States, people call them emerging adults. But as we know, the brain is still developing until age 25. although I know some people in the 60s that the brain is still haven't completely, matured. But nevertheless, emerging adults have a lot of issues and in terms of development. And I'm not giving a talk on marijuana, but it's so important to talk about how exogenous cannabis affects pruning and myelinization of the developing brain. So that's really interesting. And we found out actually, especially in the United States, that first year in college is a very dangerous year in terms of high risk for pathology, because in many other countries, people go to college and many of them stay at home. But in the United States, because it's so vast and big, they go to some colleges, and if they are what you call slow to warm up to networking with other students, they become depressed, become a little bit dysfunctional, sleep late, don't go to classes, feel bad about it, so they drink alcohol and smoke some weed, and it's a slippery slope. And then also it increases the probability of suicidal behavior. And we see this kind of young people coming to our clinic. It's very important kind of to address this population. As you've seen from the title of my presentation, I'm going to address mainly depression. I don't have enough time to talk about suicidal behavior, but hopefully I'll make a couple of notes, and hopefully you're going to read or address it in upcoming conferences. So let's get straight to the issue. What is the magnitude of depression in the United States? The late Professor Gerald Kellerman from Columbia University defined or declared the 1990s as the age of melancholy. Little did he know, given his prophecy, that depression rates right now in the 2010, 2020 decade almost increased by 50%. So this is the latest information from a very large study that's being conducted in the United States that shows that adolescents are, that had at least one major episode, depression episode, this amounts to 13%. The emerging adults, it's about 11%. But what is even more substantial is that substance use among those who had one episode of major depression is almost 1 out of 3, as compared to 1 out of 6 or 7 among those who do not or have not had such an episode. Those of you who are more visual, United States, there are about 330 million, give or take, inhabitants. And so every problem, like if you look at the EU, given the number of inhabitants in the EU, we talk about hundreds of thousands of people, if not millions. So that's definitely a major issue. Furthermore, which is again a very important take-home message, the DSM system or the ICD is a little problematic, although physicians need to use it, and maybe some other mental health professional, because it's binary, it's dichotomous. You either have the disorder or not, as compared to dimensional approach, which measures the pre-treatment versus post-treatment status. What we have found out, and this is a seminal paper by Adrian Engold, it's 20 years old, in the Orange Journal, that sub-threshold diagnoses are extremely important because their effect clinically is as bad or as problematic as diagnoses that have been met. So for example, in depression, you need to have 5 symptoms to meet DSM criteria. But if you have a patient who has 4, 3, or even 2, does it mean this person does not have depression? No, they do suffer from depression, but in the United States, you won't get reimbursed. You won't get money from Blue Cross or Blue Shield or any kind of mental health agency that pays for your services. And what we have found in our ongoing study, that even if adolescents do not meet the criteria, the severity that is being measured, let's say we use CDRS, the Children Depression Rating Scale by Poznansky. It's been around since the mid-90s, that show clearly that they need treatment and they do suffer, and they have the same negative consequences, including the most worrisome, which is suicidal behavior. So the message to you is, yes, it's wonderful if a person, it's good from diagnostic perspective if somebody meets the full diagnosis, but even if they don't and they manifest symptomatology, there need to be a way to fund the treatment, because otherwise the consequences are quite problematic. So what is happening in the United States in terms of, let's say, cannabis, which is the most commonly used illicit drug? The numbers wax and wane. They're usually along the same numbers. Again, I don't have time to talk about vaping. It's interesting. I gave several talks in the last month, and I always say, a month ago, I would just mention vaping and move on. Now, when we have all this new panic in the United States, all these epidemics that we are experiencing, now vaping has become a major issue. And as you know or you don't know, anybody who vapes nicotine. However, up to 40% right now of these pods include cannabis. And kids can go to school, and instead of smoking this smelly, sweet cannabis that we're all familiar with, that teachers can detect, they can use these e-cigarettes or Juul, which is one of the companies that made like $16 billion last year, and nobody would notice is. So unfortunately, I would consider many of the kids in our schools being under the influence. And if you want to know the specific numbers, I'll say it very dramatically, but it's evidence-based. There has never been any epidemic in terms of the increase of 1 year prevalence of drug use as the vaping epidemic among our high school students in the United States. Between 2017 and 2018, there has been an increase of 78% in youth, which translates to increase from 11% of high schoolers to almost 20%. And this will still go up unless people will get very worried about the negative impact of the use of e-cigarettes and all this lipid pneumonia that is caused by all kind of adjuvants are being added to it. Again, it's not part of our discussion, but I just want to mention to you because it's a major issue. And now I get phone call from parents. My kid came out, quote unquote, from the closet. He told me that he is vaping and he doesn't know what to do and he's a little depressed and he's concerned he's going to die. So this is the only silver lining, but we know from the history of all these knee jerks and panic attacks, they last a very short time and then people forget about it. But that's kind of a warning to everybody. So what is the prevalence of dual diagnosis in adolescents? As you can see, the most common disorder is conduct disorder. Depression is quite common, some anxiety disorder, PTSD, and combination of all the above. And the odds ratio of conduct is relatively high. Depression is around 2, but depression is very common, so we see a lot of adolescents that have both. A systematic review conducted most recently show you that actually, apropos the talks yesterday about cannabis, what are the odds ratio of developing anxiety? They were kind of non-significant. Depression, odds ratio not very high, but unfortunately, as you can see, suicide attempts more than 3. So definitely the use of cannabis increases the likelihood of depression and the likelihood of suicidal behavior later on. And we know right now that there's an increase in the percentage of, it's done by weight, of THC. In the UK, they call it skunk, anything above 10%. And there's a very direct positive correlation between the concentration of THC, the likelihood of developing psychosis. But it's individual. So, what came first, the chicken or the egg? Actually, this is a book that showed that the chicken and the egg had a discussion, they have a compromise, that they're not going to argue anymore who came first, and they will go together. However, I will present to you 5 models that most of them you're familiar with and advocate at least 2 of them. So you have the same old self-medication, which means the substance use is secondary to emotional or psychological distress, and what you do, you self-medicate. And the other one, of course, is a disease model that every psychiatric or psychological stress, distress, or diagnosis followed substance use disorder. It's not very likely among adolescents because the median age of most disorders in adolescence is mid, and now it's even early adolescence, and usually this precedes the use of drug 3 out of 4. But again, unfortunately, because there is a perception that unfortunately is growing that cannabis is not harmful, so there is an inverse correlation between perception of harmfulness and use. So a lot of kids said, what do you want? There's medical marijuana, there's legal marijuana, it's no big deal, everybody does it. So we definitely see some of those problems, including, earlier age of use is directly correlated with psychosis, and this is a done deal. I mean, it is absolutely proven in so many studies, and we reviewed the literature. Another way to look at it is look at the bidirectional model. Mental health, symptomatology, and substance use disorder affect each other. The common factor effect is very important and probably the most important one, meaning that you have a trunk like a tree and branches come out of it. I've never seen an adolescent whose only problem is substance use. It's always multi-dimensional. They have family issues, and/or legal issues, and/or educational issues, and/or psychiatric issues. And we developed the Teen Addiction Severity Index, which is a version of McLaren ASI that was translated in some of the languages in the room, including Spanish, Portuguese, Italian, and so on and so forth. And we have realized that we see families, like some people call it, it's not nice, but it's a term people use, the family from hell, where you've got so much psychopathology you don't know where to start, which means there is some kind of a common liability here, and also it has been proven genetically. One of the theories, at least, is associated with the name of George Koob, who is the director of the National Institute of Alcoholism and Alcohol Abuse, is the allostatic hypothesis. To some degree, it can explain to you one of the reasons maybe for the opioid epidemic, because there is an emphasis that the substance use disorder, then there's some negative consequences from the mental health perspective, which make the person feel very, very bad. So they try to increase the use in terms of dosage, frequency, and sometimes other drugs, which, can be unfortunately also opioids. There's a recent publication by Olfson from Columbia University that addressed this issue. And we have, I don't know if I have it on this slideshow or not, there was a study conducted in Connecticut, not by myself, on 50,000 adolescents that showed clearly that those who use cannabis use prescription opioids 4 times more, other drugs 5 times more, and heroin 14 times more. So this is not the chronic pain issue that everybody jumps on when we talk about adults and opioid addiction and the opioid epidemic, because most of those adolescents do not have chronic pain. They started with alcohol, cigarettes, and cannabis, and it deteriorated into prescription painkillers and heroin. So there is a Dutch study published last year, and it's a meta-analysis of 13 studies that show you that the odds ratio of depression and substance use disorder is 2, okay? So this definitely suggests shared liability. And as you can see, there's so many ways of looking at the relationship, but the bottom line is, I think that we should advocate for the shared liability model and not just be very, very specific. Another issue, again, is part of this discussion whether cannabis is good or cannabis is bad. From my perspective as an adolescent psychiatrist, I'm against legalization, period. In my little state, Connecticut, we are fighting it back. I don't know how long we will be able to hold the trenches, but the bottom line is that we even see here that just negative affect is associated with depression. So some people use marijuana and say, oh, I feel better. They might feel better for a short while, but later on there might be an exacerbation of depression, and by the way, also anxiety disorders, and increase in suicidal behavior. So it will be nice to see all those studies on CBD, on cannabidiol, and mental health problems, but right now I'm very leery about this issue because it's so difficult to find out that how cannabis or even CBD is useful because we are not sure about the ratio between CBD and THC, and there's what we call the entourage effect or the other terpenes associated with it. So hold your horses, and as far as I'm concerned, if you work with adolescents, there's absolutely no reason to advocate for the use of cannabis unless they're very little babies who have epilepsy, which is Dravet syndrome, or Lennox-Gastaut, where they seize 100 times a day. This is the only indication for infants and children. Otherwise, absolutely, there's no indication for use of cannabis in a therapeutic way. There's some studies on autism, but we'll wait and see where they lead. But this is right now what we know. It's only about the Pediolox product, which, by the way, was produced by a company in Connecticut. Some people talk about protective factors of internalizing disorders, and the idea is that we don't always need to look only at the pathology, but also at the personality underneath the pathology. People who have internalizing disorders such as anxiety and depression don't necessarily join the crowds of the kids with externalizing disorders. They're more shy, more private, and they use it and with trepidation. They are concerned about the consequences. So that might be an issue that is useful. So we cannot ignore any more substance abuse patients with mental illness, because having other mental health issues or substance use issues is troubling enough. Having both of them, as you can see from the slide, increases the severity, decreases the likelihood of compliance in treatment and engagement, and increases negative consequences, and elevated risk for suicide, greater treatment attrition, and so forth. This is a slide from The Economist. Unfortunately, globally and in Europe, suicide is going down. In the United States, it's going up. And unfortunately, the segment of population where it's going up most rapidly is at 10 to 14 years old. And girls at a rate of 2.5 more than boys. I'm talking about complete suicide. So everybody wants equality, gender equality. Unfortunately, gender equality regarding suicide, this closing gap becomes a major, major problem right now for adolescents. I wish I had more time to talk about it because it is very important, as you can see for these slides, to understand that any drug use increases dramatically the likelihood of suicidal behavior, and any other psychopathology adds even more to that. So let me just show you two more slides, and then I'll be done. Usually this is like a 45-minute presentation, but I'll try to summarize it very briefly. As I mentioned before, adolescence is the most neglected sector of society per age. As you can see, a quarter of the population of the United States is under the age of 25. Unfortunately, roughly speaking, only 10% of resources are allocated, and I don't want to say anything to the other representative here, if they are or is or are. Please allocate more money to the research of adolescents, because this is the next generations of addicts, and putting all this money in older people is usually a tendency among NIDA and AAA, but it is so important to invest in research of very young people. One last issue, because I don't have much time to talk about treatment and why there is this dichotomy between systems, because they're like silos. People who do mental health, people who do substance abuse, and this is why WADD, the World Association of Dual Diagnosis, a relatively new organization that hopefully you'll check it online, is trying to put these two pathways of pathology together, because it's not enough just to say there is an additive effect. We need to find an integration to do it. And furthermore, and again, I'm going to end with this here, is to let you know that adaptive treatment is the way to go. The same like with medications. We have found out in our ongoing study that even if you treat dual diagnosis depression just by cognitive behavioral therapy for substance use disorder, close to 40% of the people with depression, it becomes subclinical, which means there are common mechanisms of behavior change. However, what we are all interested in are the poor responders to treatment, because they are the high utilizers of our system. We usually say that 20% of the patient take 80% of the resources. So we need to know how to improve the treatment, and that's why we do an adaptive treatment, which is like a decision tree or an algorithm with medication. If this works, it's great. If it doesn't work, you increase dosage. If not, you add another intervention, integrated intervention, or keep on switching on. So I will stop here. Hopefully there'll be time for questions at the end of, or at the end of it, and thank you very much.
Well, thank you very much, Yifrah, for this wonderful talk. I'm really sorry to harass you, but...
To rush me, not to harass.
Well, thank you. As I was saying earlier, for me it's a great honor to be here in this table, and especially to present Roger Weiss. Back in the 80s, back in the 90s, sorry, I had the opportunity to be in McLean, and that too, when I was still a student, and as I said, he's one of my references and teachers in addictions. Roger Weiss is currently professor of psychiatry at Harvard University. He's also a chief at the Alcohol and Drug Abuse Division of McLean Hospital, and one of the major researchers in the areas of dual disorders, one of the earlier researchers. Roger.
Thank you very much. It's always, it's great to be here, and I really appreciate the introduction by Dr. Martinez Raga. It's great to see his career has blossomed so well. So today's talk, I'm going to be reviewing comorbidity in the treatment of opioid use disorder, focusing on pain and depression, and I'm going to be taking data from the United States multi-site prescription opioid addiction treatment study and some ongoing research that we're doing at McLean Hospital and Harvard Medical School. So the prescription opioid addiction treatment study, where I'm going to be talking about some of the data, compared treatments for prescription opioid dependence using buprenorphine naloxone of varying durations and counseling of varying intensities. It was conducted as part of the National Institute on Drug Abuse Clinical Trials Network at 10 sites in the United States, and it's the largest study ever conducted for prescription opioid dependence with 653 participants, and it included a 3.5-year naturalistic follow-up study, and I'm going to be talking about some secondary analyses from that study. So I'm going to be using data from that to talk about comorbidity with pain. So in our study, we defined chronic pain as pain other than everyday aches and pains, not counting withdrawal pain, for at least 3 months. It was assessed with the first question of the brief pain inventory, and 42% of patients in this study met this criterion. So one of the things we asked was for people who did report chronic pain, what was the primary reason that they initiated opioid use for the first time? And 83% of them said that they initiated it for pain. We then asked that 83% who initiated it for pain, what's the primary reason that you're using opioids now? And only about a quarter are still using primarily for pain, more than half to avoid withdrawal, and a relatively small number to get high. And so I think what that shows is what people who work with this population know, which is that whatever starts an addictive process is not necessarily the same thing that maintains it, and that focusing on how this all began may be useful to some extent, but you really need to focus on the current precipitants for use, and they may be quite different. So one of the questions that we had is whether people who had chronic pain when they entered the study predicted successful outcome on buprenorphine at 3 months. That was our primary outcome measure. And the answer was no, that people had the same general outcomes whether or not they had chronic pain. But then when we looked at, instead of looking at does pain predict long-term outcome, we looked at week-to-week outcome. And what we did find is that severity of pain in any given week increased the likelihood of opioid use in the following week. So it was a good marker. And if every 1 point increase in pain severity was associated with a 15% greater likelihood of opioid use in the following week, and a change in category, for example, from mild to moderate, led to a 32% increase in the odds of the next week use. So it's a good marker of risk for near-term use. Then we were interested in chronic pain over time, and this is some research that we're doing right now. So in our long-term follow-up study after the main trial was over, it was a naturalistic exploratory study with the aim to examine long-term outcomes of participants in the main trial. So participants were interviewed 18 months, 30 months, and 42 months after entering the trial with telephone interviews that lasted about 45 minutes to an hour. They were all paid $75 for each interview, and what we found is that the prevalence of chronic pain, which was 42% at the beginning, steadily dropped at each time period, so that it was only about half that when by month 42. But one of the things that was interesting is that 25% of those who reported chronic pain at study entry never reported chronic pain again. And the average duration of chronic pain for people entering the study was 4.5 years. So it's not as if they just developed the pain. They'd had pain for years, and then they never had it again. 28% reported who had chronic pain at baseline reported having it sometimes in the future, but not always. And only 18% of people reported chronic pain at every follow-up visit. And this is really different from the course of chronic pain in patients who don't have opioid use disorder, where it doesn't just typically remit. This could be related to hyperalgesia. That's one of the ideas, because the presence of chronic pain over time correlated with ongoing opioid use at the time. So it's quite possible that people who have chronic pain and using opioids, when they stop using opioids, the pain gets better, not worse. And of course, their fear is that their pain will get worse when they stop using opioids. So I want to talk about depression comorbidity and opioid use disorder. So patients with opioid use disorder are at increased risk of having a mood disorder. So from the National Epidemiologic Survey on Alcohol and Related Conditions, the NESARC study of 43,000 adults in the United States, for patients with opioid use disorder, about half have a lifetime mood disorder, mostly depression, some mania, and the odds ratios of mood disorders are quite high, with an odds ratio of about 5 for any mood disorder, and over 6 for mania, nearly 10 for women for mania. On the flip side, if you have major depressive disorder, you are more likely to have prescription opioid misuse. So for adults, 12% of adults with major depressive disorder have misused prescription opioids, which is 3 times the rate of people without major depressive disorder. And in adolescents, it's almost 3 times as great, 8% versus 3%. So having opioid use disorder is a risk factor for mood disorder. Having mood disorder is a risk factor for opioid use disorder. Depressive symptoms precipitate treatment seeking in patients with opioid use disorder. There was a classic study that was done many years ago at Yale by Bruce Rounsville and Kathy Carroll, in which they wanted to compare people who were in treatment, this was a methadone maintenance treatment program, with people who were still in the community continuing to use heroin. And what they did was they did a number of standardized assessments of people who were in the methadone treatment program, and they used what's called a snowball technique. They asked the people who were in the program, do you have a friend who's still using heroin? And we'll give you $10 if you can find somebody to bring in. And they would bring somebody in. That person would fill out the same assessments And then as that person was leaving, they'd say, we'll give you $10 if you can have a friend that comes in and meet. At some point, there's a line around the block of people coming in to fill out assessments, and they looked at what was different in terms of these assessments between the people who were in the program and people who were still using. And what they found was that the single biggest difference was the level of depressive symptoms. So it was not severity of addiction, number of negative consequences, getting fired, getting arrested, et cetera, et cetera. So we're all taught when we see patients to ask, why are you coming into treatment now? And the answer is usually some sort of external event. Well, I'm coming in because I got fired, because I got thrown out of my house, because I got arrested, or something like that. But people who are coming into treatment, they report that, but for everybody coming into treatment, there's somebody still using who had the same thing happen. But the difference was that this happened and it really affected this person, that they developed depressive symptoms as a result of that. So it's not just the event, but it's the event plus the response to the event that ends up driving people into treatment. Unfortunately, for methadone maintenance treatment, people with depression tend to not do as well in treatment. But for buprenorphine treatment, that's not necessarily the same story. Depression and even suicidality may actually be a good prognostic sign for buprenorphine treatment. So in the prescription opioid addiction treatment study, when we looked at predictors of successful 12-week opioid use outcome on buprenorphine, the single best predictor of good outcome was having lifetime major depression. Not exactly what we expected to find. It was really the opposite of what we expected to find, but we found it. So people with major depression were nearly twice as likely to have a good outcome as people who didn't have major depression. The single worst prognostic sign was using a prescription opioid in a way that it was not intended to be used, meaning you crushed it, chewed it, snorted it, injected it, did something other than take it the way you're supposed to take it. So then the question is, why would depression be a good prognostic sign? Well, another question is, was this just a one-off finding? But maybe not, because there was a study by Markovitz et al. That was a retrospective medical record review from 3 different clinics looking at predictors of early dropout. A couple of the findings were expected. Young age predicted early dropout. Opioid use in the first month of treatment predicted early dropout. But a history of suicide attempt predicted greater retention. So there's a couple of studies now that show that there may be something about depression or suicidality that predict good outcome. We're in the process of now analyzing the data, trying to figure out what did it. So one theory was buprenorphine has been purported to have antidepressant properties. Perhaps the reduction in depressive symptoms, that is the reason that those people did well. We found that was not an explanation. And we wondered, well, maybe these folks were more motivated to abstain. So, because we asked people, what's your goal for treatment when they entered the trial? Do you want to be completely abstinent? Do you want to just use every once in a while? That didn't turn out to be anything. Then we wondered whether there was better treatment engagement, and one way we could measure that was, did they go to more mutual help groups, which we found in our long-term follow-up study was associated with good outcome. The people with major depressive disorder did, in fact, go to more mutual help groups, such as Alcoholics Anonymous, Narcotics Anonymous. So there may be something about more motivation to change. There's a little bit of data showing people with substance use disorder who have psychiatric illness are more motivated to make changes in their lives. They're more unhappy with their lives. But we're still trying to understand this kind of ironic finding. So the other area in terms of opioid use and depression that we've been researching at McLean Hospital is on opioid use disorder and suicidality. So this slide, which I'm sure a number of you have seen, basically shows the increase in opioid overdoses in the United States over the past dozen years or so. And so one of the questions that we've had is whether overdose and opioid use disorder, the degree to which this is accidental overdoses, whether it's suicidal or something in between. We know that suicide risk is elevated in opioid use disorder. It's higher in opioid use disorder than in other substance use disorders. 30 to 45% of people with opioid use disorder report a history of suicide attempt at some point. Among veterans with opioid use disorder, the suicide rate is 6 times that of the general population. The magnitude of suicide risk in females with opioid use disorder is 8 times that of females without opioid use disorder, and about double in men. So when I first started in the field some years ago, like in the first month or so of my job, I asked a patient, what goes through your mind after you've injected heroin in the couple of seconds before you feel the effect? And he said, I'm either going to get really high or I'm going to die. I hope I get high. So I always remembered that statement. And so I think of this population as having a combination of what I call pathological optimism, meaning if I fall out of a tree, I think I'll land on my feet, and fatalistic pessimism, which is, and if I land on my head, that's okay too. So I think that statement that he made is sort of a combination of those two factors. And so when I think of overdose, I think there's, instead of thinking of it as accidental versus suicidal, I think there is a continuum that can go from I don't want to die and I don't think I will, but I know it's possible. That's basically what this person said to me years ago. Today wouldn't be the worst day to die, or I might be better off dead, or I don't care if I live or die, or I want to die today. And there's a continuum there, and we were interested in looking at this. So we have been conducting a study at McLean Hospital, and people admitted to our inpatient detoxification and stabilization unit for 120 opioid use disorder patients. About half of them had overdosed at some point. The mean number of overdoses in that population was 5.3. The median was 3. And so the first thing we were interested in is to look at people who had overdosed at some point versus people who had never overdosed. And so the differences in the next couple of slides are everything that's red in red print is a difference between the people who had overdosed and people who had not overdosed. So the people who had not overdosed were not surprisingly more likely to be employed full-time. Their primary opioid problem was mostly heroin and or fentanyl instead of prescription opioids. Their treatment history, they'd been in a lot more treatment, and they had an earlier age of onset and an earlier age of initial treatment. More likely to have a co-occurring psychiatric disorder. 3 times more likely to have made a suicide attempt, more craving, earlier age of benzodiazepine use, and paradoxically and interestingly, less marijuana use. So the 53 patients that had overdosed, we asked them 2 questions. Just before your most recent overdose, how likely did you think that you would overdose on a scale of 0 to 10, from no chance to extremely likely? And just before your most recent opioid overdose, how strongly did you want to die? Again, 0 to 10. So The first question was the degree to which it was accidental. How likely did you think that you would overdose? Only 30% said 0. The mean score was 3.1. 28% said at least 5, and 13% said 10. Then we asked people, just before your most recent opioid overdose, how strongly did you want to die? Again, 0 to 10. Less than half said 0. The mean score was 3.8. Over a third said at least 7, and 21% said 10 out of 10. So I think what that shows is that these are patients who are at high risk of suicide. Many opioid overdoses have at least some suicidal component with it, if not a frank attempt. Post-overdose evaluation really needs to address suicidal intent. Chronic pain, which I had talked about before, is common among patients with opioid use disorder and is a clear risk for suicide. Depression is common and is a risk for suicide, but could actually be a good prognostic factor in buprenorphine treatment. And attention paid to this comorbidity is critical and may improve outcome in opioid use disorder patients. So I'd like to acknowledge the National Institute on Drug Abuse Clinical Trials Network grant, and I guess this isn't a time for questions, but at some future time.
Comme les orateurs respectent bien leur temps, ça nous permettra d'avoir un temps de discussion après les exposés. Donc, c'est un très grand plaisir, un bonheur de vous présenter et d'accueillir le professeur Yifrah KAMINER. Yifrah KAMINER qui a de nombreux titres et qualités, mais particulièrement, je veux répéter qu'il est avec Jean-Jacques Desglons, Jean-Marie Guffin, etc. Il est aussi au départ des colloques ATHS. Il est par ailleurs le président, l'animateur dynamique de Europad, et Europad qui réunit l'année où ne se tient pas le THS, réunit la famille de ceux qui sont engagés dans cette démarche de l'addictologie, de la pathologie duelle humaniste. Donc Yifrah KAMINER est psychiatre, addictologue, il est professeur à l'université de Pise et il est le chef du service à l'hôpital universitaire d'une unité qu'il a appelée et qui s'appelle donc une unité de pathologie duelle, Vincent Doll, si mes souvenirs sont bons. Et donc il aborde un aspect très, je crois, prometteur et intéressant de la psychopathologie de l'usage d'opiacés, de l'héroïnomanie, et sans dévoiler son sujet, je dois dire que son hypothèse vient faire écho à quelque chose qu'il y a quelques décennies, nous avions à l'hôpital universitaire de Bordeaux, quand nous démarrions dans le service de psychiatrie, le soin toxicomane, un petit peu évoqué. Nous avions parlé alors, peut-être, l'héroïnomane n'est pas un jouisseur, mais peut-être un douloureux chronique. Yifrah, avanti.
Thank you very much, Jean-Pierre, for your kind presentation. So it's a problem to do really well. And thank you to all of you for coming. And maybe it's strange, this presentation, because we are in the domain of dual disorder. But in reality, I am thinking that a specific psychopathology of heroin addiction, of a substance use disorder in reality exists. It's impossible that our patients haven't emotion. We are used to consider the psychopathology of depression, the psychopathology of schizophrenia. Why not a psychopathology of substance use disorder? Not comorbidity, but to have a symptomatology, a psychopathological dimension due to be addicted. Because to be addicted is an experience traumatic for people and is not different from depression, from schizophrenia, and other things. So the problem is there is only craving and relapse, or there is a specific psychopathology. Many years ago, with some friends, we started to consider the possibility that anxiety, mood, and impulse control dysregulation must be included in the psychopathology of addiction. Was the time of DSM-5, of course. They did not accept our proposal. And so we started our research trying to evidentiate some symptoms characteristic of heroin addicts at treatment entry. So we used the SCL-19, that is an inventory of symptoms, not specifically for substance use disorder, but for psychiatric patients. And you can see the factorialization of SCL-90 in psychiatric patients on the left, and you can see on the right the factorialization for addicted patients, for heroin use disorder patients. We have a 5-dimension and non-9-dimension, worthlessness and being trapped, somatic symptoms, sensitivity, psychotics, panic, anxiety, and violence, suicide. In all patients arriving at treatment, not with the comorbidity, of course, also in patients with psychiatric comorbidity, but all patients arriving to the treatment can be addressed with this kind of assessment. And so, if we consider the zeta point of our patients, we can have the predominant group, the different color. And these different color are of different intensity, because some patients have a high intensity of this dimension, other patients have a low severity of this dimension. But every patient can be diagnosed in one way. In this case, our patient is with prominent worthlessness, being trapped symptoms. And we started to study the correlation between this dimension and the characteristics of addiction. For example, young people are more sensitivity to psychoticism symptoms, have more sensitivity to psychoticism symptoms and violence suicide symptoms. And older patients present more worthlessness and being trapped. And this is logic, because unfortunately the treatment for addiction is not so good as expected. And then we continue and we study the independence of the state situation of our patients. And we found that our dimensions are independent of the choice of a treatment, agonist opioid treatment of the therapeutic community, independent of active substance use, entering a therapeutic community detoxified or non-detoxified, independent of lifetime psychiatric problems, independent of the choice of a substance used, heroin, alcohol, and cocaine, and also independent of the choice of a substance used in mono-user patients, because, as you know, is quite impossible to find not poly-abusers in our patients. Is independent of stress sensitivity, independence of 3 months abstinence in non-use of a substance in therapeutic community, and also independent of ethnicity. We studied migrants and we studied the border situation as in Slovenian-Italian border. Is strictly correlated to addictive behavior and is strictly correlated to stress sensitivity. And this is another thing I'll try to explain. Of course, this dimension must differentiate the psychopathology of a substance use disorder from other psychopathology. And we can distinguish very well substance use disorder from major depression patients. We can distinguish very well chronic psychosis, not very well obesity, not psychiatric obese patients, but probably part of obese have something of addiction. On the contrary, it's possible to well differentiate, we cannot differentiate patients with the substance abuse from people with the pathological gambling. And we can also differentiate young adolescents with problematic or non-problematic internet use. So, the mood dysregulation is very similar to the dimension worthlessness and being trapped. Anxiety dysregulation is very similar to panic anxiety. Impulse control dysregulation is very similar to violence and suicide. Somatic symptom is very similar to the withdrawal syndrome in heroin addicts, especially in heroin addicts. Sensitivity and psychoticism is a little bit strange. And stress sensitivity, because we know that our patients have a difficult in stress reactivity also during treatment. In our clinic in the University of Pisa, we stressed the study of post-traumatic stress disorder and also the idea of a post-traumatic stress disorder spectrum that is something very similar as a symptom to post-traumatic stress disorder, but is in relation to loss and traumatic events, normal events of the life. And so we started to study the post-traumatic stress disorder in heroin addiction. And the first study was before and after the age at onset of heroin addiction. Is there a variation in the number of stressful life events between before and after heroin use disorder age of onset? Yes, yes. More traumatic loss and traumatic events after. We know that there is a traumatic situations that are causing substance abuse. But interestingly, there is some very similar to post-traumatic stress disorder after a long time addiction to heroin. Is there a variation in the emotional responses to stressful life events between before and after heroin use age of onset? Yes. You can see the difference is significant. And so we started to consider the idea of an unitary perspective between post-traumatic stress disorder and substance use disorder, with two questions. Are correlation between PTSD spectrum and severity of heroin addiction significant? Are opioid medication able to reduce reaction to life events in heroin addicts during treatment, during an agonist opioid treatment? And the answer is very simple. There is a correlation between the severity of addiction and severity of post-traumatic stress disorder spectrum. There is no difference in heroin intake, but there is a difference in proxy of the severity of heroin addiction. But there is more interest in these results. There is an inverse correlation between the dose of opioid medication and the severity of reaction to life events. And so the idea is that can heroin addiction generate a sort of PTSD? And this sort of PTSD, this is important to define the duration of the treatment, because there is a very strange situation in heroin addiction. The illness is chronic. The treatment is limited in time, especially in some part of Europe, not in Italy, not in Spain, not in Portugal, but in some part, especially in Northern Europe, is limited in time, probably from economical reason, but is limited in time. And I think it's the only chronic disease with the limited in time treatment. We studied the survivor of earthquake in Italy, L'Aquila earthquake, and the young people survivors to this earthquake, and we studied the reaction to life events with the post-traumatic spectrum in people with a post-traumatic disease, a real post-traumatic disease, or people without a post-traumatic disease. And we found that 32 is the cutoff dividing people with a real post-traumatic stress disorder after the earthquake and people without a post-traumatic stress disorder. If you consider people without a post-traumatic stress disorder, with post-traumatic stress disorder, long-lasting heroin use disorder patients, you can see that there is a very similar situation between people with a post-traumatic stress disorder and people with an heroin use disorder without to be exposed to an extreme traumatic, but only exposed to the illness. So probably in people with 10 years long heroin addiction, there is a sort of a post-traumatic stress disorder in life events, in normal life events. And so I want to show you the last results of our study, trying to define more specifically the characteristics of people who have an heroin post-traumatic stress disorder spectrum during treatment. And you can see that this kind of spectrum is more present in females with no partners, in people unemployed, and people with less frequent occupation, blue collar. We don't know why. As you can see, people with the post-traumatic stress disorder spectrum have more physical health impairment. They are more unemployed, with the problem in the household, with the romantic involvement problem, and with a more use of BDZ during the treatment. Also if they are in methadone or buprenorphine treatment. And some behavior is present, some risk behavior and Q environmental related or reward behavior is still present in people with this kind of spectrum. And you can see the psychopathology is correlated. Our dimensions are correlated with the presence of this post-traumatic stress disorder spectrum. But in these patients, these are patients in treatment, in methadone treatment at my research group for 27 years, means 20 until 40 years of treatment in methadone treatment or buprenorphine treatment. It's really interesting that all patients started the treatment in methadone and now are in buprenorphine. And only one is still at a dosage more than 30 milligrams of methadone. In these patients, the psychopathology is very low, the employment is very high, the social adjustment is good, is very good, but the reaction to stress events, as you can see, is still high, especially in the patients, in the last one, that is still in treatment after 40 years with the methadone at 40 milligrams. So probably we have something to use in have an idea of the proceeding of our treatment. Do methadone and buprenorphine have the same impact on psychopathological symptoms of heroin addicts? In this symptomatology, in this psychiatric symptomatology, because all patients have this kind of prominent symptomatology. And if we consider methadone and buprenorphine, you can see that patients with the prominent sensitivity psychoticism go better in methadone, and the patients with the violence and suicide dimension go better in buprenorphine. And if we consider people in the therapeutic community, also in this case, patients with the prominent violence and suicide symptomatology are not good for the treatment in therapeutic community. So, if a patient comes to the treatment with the prominent symptom of violence and suicide, they are young and probably they have a good treatment if we put in buprenorphine treatment this kind of patients. Of course, this is a proposal, is a clinical proposal, but I think that is a new way to study the psychopathology of our patients. Thank you very much for your attention.
discussion sera sûrement très riche. Après le dernier exposé que Laurent Michel va présenter. Laurent Michel est psychiatre, addictologue. Il dirige le XAPA Pierre-Nicole à Paris. Mais là, il va nous amener vers le sud-est et le Vietnam, puisqu'il intervient aussi dans le cadre d'un projet financé par le NAIDA, le projet DRIVE, à Haiphong. Et la présentation qu'il va faire va porter sur les comorbidités psychiatriques dans le cadre de cette étude de DRIVE à Haiphong. Laurent, la parole.
Merci beaucoup Jean-Pierre de m'avoir permis de présenter ces résultats qui sont finalement l'aboutissement de 4 années au moins de travail avec ces patients à Haiphong. En fait, je vais vous raconter un peu l'histoire de la mise en place d'une prise en charge des troubles comorbides, psychiatriques et addictifs, la mise en place d'une intervention originale parce qu'elle est à support communautaire dans la ville de Haiphong au Vietnam. Alors, la télécommande, il n'y en a pas. Donc je vais... Ok. Alors, juste brièvement, je vais aller assez vite. Haiphong, c'est le port du Nord-Vietnam, c'est 2 millions d'habitants et une population d'injecteurs qu'on a estimée à... Merci. À 5500 personnes dans le cadre de cette étude DRIVE, usagers injecteurs, avec l'apparition d'un usage de méthamphétamine très très important qui est, comme on le sait, tout à fait associé à des problèmes psychiatriques, notamment... alors, je branche ça sera plus simple, voilà. De problèmes psychiatriques, notamment dépression ou troubles psychotiques. Donc, il y a des traitements qui ont été mis en place par la méthadone depuis, ça marche, depuis maintenant 2008, avec 3900 personnes qui sont prises en charge. Et au plan le développement de cette intervention, le projet DRIVE, c'est mettre fin à l'épidémie de VIH dans cette population sur la base d'une intervention communautaire qui comprend la réduction des risques, le soutien à l'accès aux soins, méthadone, antirétroviraux, démarches administratives, l'accueil des interventions dans les locaux et des associations communautaires. Alors les associations communautaires, c'est quoi? C'est des associations d'autosupport pour usagers de drogue, pour travailleurs du sexe, pour hommes qui ont des relations sexuelles avec les hommes, essentiellement, mais surtout usagers de drogue, dans 2 sites de Haiphong. Et ils ont participé directement à la recherche sur le design de la recherche, les interventions à déployer, la passation des questionnaires, où on s'est rendu compte très vite que c'était beaucoup plus simple, avec des résultats plus fiables quand c'était les usagers qui faisaient passer les questionnaires plutôt que des médecins de la fac de Haiphong, et intervention aussi dans le suivi. Ah, ça ne marche plus. Alors, le projet DriveMind, qui est inclus dans cette cohorte, est de développer un accès aux soins psychiatriques pour les personnes usagères de drogue à Haiphong, en évaluant dans un premier temps les besoins de ces usagers sur le plan psychiatrique, la mise au point d'un outil de dépistage au niveau communautaire, la mise en place d'un accès aux soins psychiatriques, à soutien communautaire et une évaluation du dispositif. Donc là, je ne vais pas détailler puisque Don Desjarlais va le faire après sur l'intervention DRIVE proprement dit. Mais en résumé, c'est une succession annuelle d'études de recrutement d'usagers de drogue injectée de snowball, donc boule de neige, avec à chaque étape annuelle le recrutement d'une cohorte VIH- et VIH+. Et c'est sur ce recrutement que s'intègre l'étude DriveMind, avec initialement donc l'évaluation des troubles psychiatriques et des besoins qui s'est faite en 2016, l'évaluation des stratégies d'accès aux soins, qu'est-ce qui était le plus adapté au niveau communautaire, la validation d'un outil de dépistage qui puisse être utilisé par les associations d'autosupport, et le recrutement proprement dit d'une cohorte sur une période de 12 mois pour évaluer la pertinence de l'intervention. Alors, l'évaluation des troubles psychiatriques, donc on l'a faite après validation en vietnamien du questionnaire mini, donc il y a un entretien structuré qui reprend les critères du DSM pour l'évaluation des troubles psychiatriques. On retrouvait dans cette cohorte, donc chez des gens déjà suivis, ce qui explique la faible prévalence finalement des troubles psychiatriques, 25% présentant au moins un trouble psychiatrique, mais parmi ces 25%, aucun ne sont venus à ce qui leur était proposé pour un suivi, c'est-à-dire des consultations ou une prise en charge au département de santé mentale, traduisant l'importance de la stigmatisation pour les usagers, à la fois des troubles mentaux, mais aussi des soins de santé mentale, des difficultés qu'ils pouvaient rencontrer pour ça. Aussi la question du coût des soins, puisqu'il fallait avoir une assurance sociale et encore elle ne prenait pas l'intégralité des soins en charge. La distance et bien sûr c'était des usagers actifs, donc le centrage sur le produit. Donc c'était le constat qu'il fallait développer une intervention qui permette au niveau communautaire de des soins avec des stratégies qu'on a développées dans les temps qui ont suivi, avec le constat qu'il fallait développer les consultations psychiatriques dans les sites communautaires, qu'il fallait non pas faire des prescriptions uniquement, mais remettre les traitements gratuitement au moment des consultations aux usagers, et surtout accompagner ça d'une formation importante des associations d'autosupport, puisque plus de 40 membres des associations d'autosupport sont maintenant salariés dans le cadre de ce projet Drive global. On a fait un outil de dépistage qui est un outil en 9 questions qui permet aux associations d'autosupport de repérer les troubles psychiatriques dans cette population, ou du moins de donner une indication là-dessus, mais surtout qui permet d'introduire la question de la santé mentale auprès des usagers, ce qui, je pense, est très intéressant, avec une validation qu'on a faite donc sur des usagers de la cohorte Drive, avec une sensibilité qui est acceptable pour un score seuil de 2, mais en refaisant la même validation chez 318 jeunes usagers à Hanoï, usagers de méthamphétamine essentiellement, on s'est rendu compte que le score seuil n'était pas le bon, mais vu la discussion qu'on a eue ce matin, je pense peut-être aussi que dans ces jeunes populations, ces outils ne sont pas forcément adaptés ou reflétant les mêmes choses que pour une population plus âgée. Pour le recrutement de la cohorte a débuté il y a 6 mois. Donc, parmi les usagers de la cohorte Drive, donc 1700 initiales, 1200 qui ont été revus dans cette visite du 30e mois, et parmi ces 1200, 233 présentaient des troubles psychiatriques dépressifs essentiellement ou psychotiques liés aux méthamphétamines notamment, et ont été intégrés ont accepté d'être intégrés dans cette cohorte. Donc vous avez quelques caractéristiques ici de cette population, essentiellement bien sûr masculine, avec un passé d'usage d'héroïne important, parfois largement au-delà de 15 ans, et d'un Global Impression Scale, au moins 20% qui avaient des troubles considérés comme sévères. L'intervention diagnostic et suivi gratuit dans les sites communautaires, remise gratuite des médicaments aux patients, un défraiement des transports aussi pour ceux qui habitaient les plus loin, enfin de manière générale. Une formation des membres de l'autosupport, donc qui étaient réticents au début à aborder la question de la santé mentale et qui l'ont vraiment adopté et l'ont repris à leur propre compte après un travail de formation, d'accompagnement et surtout l'élaboration ensemble d'outils de communication, notamment de flyers. Un suivi par l'autosupport, c'est eux qui font le rappel des rendez-vous, c'est eux qui ont les contacts avec les familles, c'est eux qui font les interventions de réduction des risques et d'information. Donc là, on est à la visite de 6 mois. Le constat, un des constats cruels, c'est que sur les 230 personnes, 9 sont décédées. Ce qui est quand même évidemment inquiétant. Aucun de suicide, un d'overdose, plusieurs pour des affections somatiques, cirrhose ou VIH ou sida, mais 195 ont été revus, c'est-à-dire un taux de rétention de 87%, qu'il faut comparer au fait que personne n'avait accepté d'être revu initialement, avec un succès bien plus évident sur les troubles dépressifs, moins sur les troubles psychotiques, ce qui reflète, à mon avis, et qui nie une analyse un peu plus poussée, parce que très clairement, un certain nombre de patients avaient des troubles psychotiques associés aux troubles dépressifs, et que les troubles psychotiques sont pour certains liés aux méthamphétamines, mais nécessitent des interventions un peu plus structurées que sans doute ce que pour l'instant on a proposé, mais il faut qu'on ait une analyse plus fine des résultats. En termes d'évolution de la situation clinique, on peut voir que plus de 70% sur l'estimation des psychiatres étaient nettement améliorés sur le plan clinique. Donc vous voyez la déclinaison ici de ces différents éléments. Ce qui nous pousse en termes de discussion, montrer que le développement d'une intervention psychiatrique à support communautaire paraît faisable et paraît être un succès à 6 mois, mais évidemment, c'est une cohorte de 12 mois, il faut attendre 6 mois supplémentaires pour avoir une idée plus précise. Se posent bien sûr les conditions de reproductibilité et de pérennisation de ce type d'intervention, et bien sûr de caractérisation de ce perdu de vue et de ce décédé, pour voir quelles sont les modalités d'adaptation du dispositif pour ces personnes. Et voilà, j'en ai fini. Donc.
So we have more or less 10-15 minutes for questions. Somebody of the audience can start.
Hello. I have a question for Professor Mariamani, which is the SCL90 can change through time. And so I'm wondering if you have information about how SCL90 or even your heroin-related PTSD ratings change through time during treatment for heroin use disorder, as opposed to just sort of what appeared to be more of a cross-sectional glimpse at a specific time point. Do individuals see improvement in these ratings through time?
Thank you for the question. We are trying to have some point to understand when the treatment is successful, because to stop the use of heroin is not a sign of success, because they can stop but they can use alcohol, they can stop but they can use other kind of medication, and there is the problem to have the point. Psychopathology is improving during treatment, is improving and is changing, in the sense that what less than being trapped generally disappear as a predominant during treatment, and longer is the treatment. And also post-traumatic, the spectrum of post-traumatic stress disorder is decreasing during treatment, especially if the dose of methadone is higher. We don't know with the buprenorphine, because the kinetics of methadone and buprenorphine are different. But with the methadone, as in psychiatric comorbidity, we must generally to use over-standard dosage, especially if patients are depressed or with the suicidality. So if we use a little bit more dosage of methadone, psychopathology and traumatic and post-traumatic spectrum is decreasing in time.
More questions? Please introduce yourself. If not, I have a question for all the speakers. All of you mentioned the suicide. That is an important fact, dangerous and sad fact sometimes. How, from your point of view, how we can avoid suicide? Because you mentioned suicide in patients suffering pain disorders, patients suffering post-traumatic stress disorders, patients with other psychiatric comorbidities. How we can avoid? Two minutes.
Thanks for giving me the microphone. That's a pretty complicated question. I think if you're just looking at it in a more, I'll talk about it in the United States, where the suicide epidemic, or not necessarily epidemic, but the suicide rate has gone up and life expectancy has gone down for the last couple of years in the United States, which it had never done before. And there's really, if you look at that rate, a lot of it has to do with education, not drug education, but education itself, and that you've got a large number of people, and this also goes along with the opioid epidemic, a lot of people in areas in which their hopes for success are not very high, and there's a sort of a sense of despair about their lives, and yet there are many other people who are more highly educated who are doing much better than that. The huge disparities in wealth and job prospects, et cetera, between the highly educated and the poorly educated, and I think from a big picture standpoint, getting away just from the drug issue, there's the issue of general education and trying to support that, at least in the United States.
Yes, I think that it will be a good idea to improve the access to the treatment for all kind of treatment, and maintain in treatment also people no responder, because this is a big problem in Europe, but also I think in United States, because people not responding to the treatment generally go in the street. And remaining in treatment is, in my opinion, the most important conservative for life of the patients.
And the other.
Peut-être ce que je peux te dire, moi, dans le contexte du travail que l'on a fait au Vietnam, c'est que au tout début de l'intervention, il y a eu plusieurs suicides parmi la population suivie, et que c'est un phénomène qu'on a pu observer ensuite. Et ça, je le mets en lien pas forcément avec uniquement l'intervention psychiatrique, mais sans doute avec la multiplicité des interventions et globalement le soutien communautaire que les personnes à Haiphong ont pu avoir de leur père, et que avec une évaluation des besoins malgré tout individualisés auxquels on pouvait répondre, il y a en tout cas, à mon avis, un impact sur le suicide proprement dit.
Any more questions? So if there are not more questions.
Voilà, donc c'est bien pensé, terminé, les questions. Donc on va remercier beaucoup nos présentateurs pour leurs excellentes présentations. Et à bientôt pour une autre session de pathologie duelle.